Welcome to a really high yield explainer on a topic where, let's be honest, preparation can be the difference between life and death. We're going to sharpen your skills for the final FRCA exam, focusing on one of the most critical things we do, identifying the difficult airway. So let's kick things off with a number that really sets the stakes, 25%. A quarter of all anesthesia-related deaths are because of a can't intubate, can't oxygenate, or CICO situation. That stark number is exactly why a thorough, systematic preoperative assessment isn't just a nice-to-have. It is absolutely non-negotiable. Okay, here's our game plan. We're going to follow a really systematic approach, just like you would in a real-world preoperative assessment, to build a complete picture of airway management, from the first questions you ask, all the way to locking in your final strategy. First things first, let's get our definitions straight and really understand what it is we're trying to prevent.
The really crucial thing to get from this definition is that a difficult airway is not just about a tricky intubation. It's so much broader than that. It includes any struggle with face mask ventilation or even getting a supraglottic airway in. Why? Because our number one job, above everything else, is to keep that patient oxygenated.
Your assessment really starts the second you start talking to the patient. Think of this as your initial intelligence-gathering mission. For your exam, you've got to be systematic. Always ask about previous anesthesics. Hunt down those old notes for any clues. The patient might even have a DAS alert card. And be on high alert for conditions you know can cause trouble, like the joint immobility and rheumatoid arthritis, or the classic bamboo spine of ankylosing spondylitis. And listen, a history of neck surgery or radiotherapy, that's a major red flag. The airway can be a real battle even if things look totally normal on the outside. You need to really listen. Listen to the sound of the patient's voice and their breathing. Is there any stridor? Is their voice hoarse? That could be a sign of an impending airway obstruction. And a history of heavy snoring and being tired all day? That's the classic triad for obstructive sleep apnea, which is a huge predictor of difficulty with both mask ventilation and intubation.
All right, so we've gathered our intel from the history. Now let's move to the bedside and build on that understanding with some essential hands-on tests.
We'll start with a true cornerstone of airway assessment, the modified Mallampati score. It gives us a direct, though, imperfect window into the patient's anatomy. And what's it really looking at? One key relationship. How big is that tongue relative to the space in their mouth? Now, what you're seeing here is a really clear visual progression, right? In class 1, you can see everything. By the time you get to class 4, the tongue is totally obscuring the view, and all you can see is the hard palate. For the exam, just remember it's classes 3 and 4 that should make you sit up and really start thinking about a difficult laryngoscopy. And this slide illustrates another absolutely key measurement. The thyromental distance, or TMD, tells us about the submandibular space. So why do we care? Well, during laryngoscopy, this is the space you have to displace the tongue into. If that distance is short, say less than 6 centimeters, it suggests there just isn't enough room to move the tongue out of the way, which is probably going to wreck your view of the glottis. Now this is a fantastic high-yield mnemonic for your exam. The 3-3-2 rule is a super quick way to combine 3 assessments. You're looking for a mouth opening of at least 3 of the patient's own fingers, a thyromental distance of at least 3 fingers, and a distance from the thyroid cartilage to the floor of the mouth of at least 2 fingers. Simple, quick, effective. But don't stop there. We also have to assess dynamic movement. Can the patient actually protrude their jaw? The upper lip bite test, by the way, is one of the most predictive single tests we have for difficult laryngoscopy. And critically, you have to assess neck extension. Their ability to get into that sniffing position is fundamental for lining up the axes to get that direct view we're looking for. So, individual tests are good, but we can really increase our predictive power when we combine them into scores, and sometimes use advanced investigations to look a bit deeper. Okay, so scoring systems like the Wilson score are designed to aggregate multiple factors, everything from weight to jaw movement, to give us a more robust prediction. A score of 2 or more correctly predicts about 75% of difficult intubations. But, and this is a big but, look at the false positive rate. These scores raise your index of suspicion. They are definitely not a crystal ball. So what happens when your bedside assessment is inconclusive? Or maybe you suspect something very specific, like the trachea is being compressed by a mass. Well, that's when we need to bring out the big guns and investigate further with imaging. Wow, this comparison is incredibly powerful. Nasendoscopy lets us look directly at the upper airway while the patient is awake. On the right, you can clearly see how distorted the anatomy is from epiglottitis. But here's the crucial warning. A nice, reassuring view in an awake patient does not guarantee an easy time after anesthesia kicks in and all that pharyngeal tone is lost.
And then you have advanced imaging, like CT. This gives us a level of detail that's just impossible to get from an external exam. This 3D reconstruction gives us a completely unambiguous view of this patient's subglottic stenosis. We know its precise location and severity, and that allows for some truly meticulous planning. Okay, this is a really important point. A thorough assessment isn't just about predicting a difficult intubation. It's about predicting difficulty at every single stage of airway management.
Before you even think about picking up a laryngoscope, you have to answer this one critical question. Can I mask ventilate this patient? This is arguably the most important skill we have in airway management, and if you can't do it, your patient is at the absolute highest risk.
And here is another must-know mnemonic for your exam: obese. These are the key predictors for difficult mask ventilation. We've got obese, bearded, which just makes getting a good seal so hard, elderly, snorer, and edentulous, where their cheeks can collapse inwards. If you spot 2 or more of these factors, the risk goes way up.
Okay, let's bring it all home. All of this information we've gathered, it's not just for documentation. It's the absolute foundation for building a robust, flexible airway strategy. This right here, this is the core philosophy you have to take into the exam and into your daily practice. No single test is foolproof, ever. Your strategy must be built on a combination of findings from the history, the exam, and any investigations. And most importantly, it has to include backup plans. And this is the final takeaway. A truly successful airway assessment isn't one that just prepares you for what you expect. It's one that prepares you for what you don't expect. It's about having Plan A, Plan B, Plan C, and Plan D ready to go before you even start. That, right there, is the hallmark of a safe anesthetist.